we should start thinking about what happened in the globe 2 years ago. 6 million people, over 500 million confirmed cases. So the health system had to adapt fast. Right in the beginning of the pandemic, we published a statement as how the system should get prepared to treat patients with neurocritical diseases, including the hospital care, how to protect health providers, and some specific considerations, such as medications. We would never consider about that. Pandemics took place in a time where we had to face incorrect information, fake news with no scientific evidences. And it was difficult not only to restrain the virus dissemination, but also to give proper information about the disease. The lay media announced a correlation of COVID-19 and the relationship to brain and lungs, and the possibility of patients with the COVID to develop stroke. That was a lay information, and the association was in doubt if that was a cause association or just a coincidence, and some more specific studies were conducted to try to understand not only the correlation between stroke, brain, and COVID. And that is a reminder to reason, despite the COVID-19 pandemic has unexpected idea, the clinical aspects, they have to be kept. It's not because we are in a pandemic setting that we have to approve those therapies with no scientific approval, or that they should be accepted by the society or medical community. Even in face of pandemic, we do require clinical trials to be conducted fast, and we have to answer to those questions properly. And the scientific setting could properly answer fast to this pandemic situation. Right in the beginning, the infection of SARS-CoV and MERS-CoV, we could tell the potential of the virus to be neurotrophic, to penetrate in the central nervous system, where that would be a entrance door to the central nervous system. Clinical symptoms of asthenia, that was a characteristic symptoms of COVID, as well as some other neurological symptoms, such as headache and some other respiratory symptoms. So should we, in addition to this impairment, could the virus cause some other neurological aspects described in some other organs associated to the infection? So we described endothelite caused by the virus, explained a number of respiratory aspects, such as thrombotic events and the viral infection in the endothelium in an early phase. That is an MRI, a nice MRI of a physician who contracted COVID-19, and we can see an edema in the olfactory bulb where there is anosmia developed after a few days, when the patient no longer has the deficit, olfactory deficit. Clinical assessment and image assessment helped us to better understand the pathological involvement and the potential causes of cerebral involvement and some inflammatory alterations and immunological changes associated to the virus infections. Despite the fear of viral encephalitis, there are just few cases described in the literature. Here we have the temporal involvement of a patient with COVID-19. Here we have a clinical description. Everyone would fear the different states of encephalitis as a clinical manifestation of COVID-19. Despite being neurotrophic, a neurotrophic virus, we could see much more encephalitis in our patients. Here we see in China for the first time a case series of 2.8% of patients hospitalized due to COVID with a cerebral involvement. That was a retrospective observational study highlighting this neurological manifestation with a coronavirus diseases. There are several reasons for that, as there is an association with an increased disease severity in patients with COVID-19, and there are several clinical manifestations, including the microvascular involvement, and large vessels involvement. This is a recommendation by the Brazilian Academy of Neurology and the Brazilian Society of Neuroinvolvement, suggesting a protocol to better protect patients, health providers. When should we use the protected stop codes? Those in the services, they would not only wear masks, but also eye protection if there was a risk for intubation. When should we intubate a patient for a mechanic procedure? All this was part of our service list to better look after our patients with the COVID. We have a number of case series in the literature where patients, they had some sort of neuro involvement, encephalopathy, patients in the ICU. This is a French publication, 58 patients now with SARS, and a description of 69% of patients that reported agitation, mental confusion, 67% of pyramidal signs. And the question is if there is any breakage of that brain barrier. And 11 of 18, they had frontal and temporal hyperfusion. The most severe cases, they showed this encephalopathy. So hypoxemia is one of the causes to increase the neurological involvement. Here we see a publication of the initial phases with some features of MRI, especially for those patients that were highly hypoxemic. And here there is a cortical involvement as well. After a cardiorespiratory arrest, we could see at those hospitals with a much higher volume of patients, a greater number of cardiorespiratory arrest followed by encephalopathy. Here we have an example of a patient with acute respiratory syndrome with a long length of stay, encephalopathic changes according to her encephalogram after a cardiorespiratory arrest for 6 minutes. We managed to revert that cardiorespiratory arrest. Here we can see those wave signs in the frontal bilateral portion, suggesting significant encephalopathy involvement. How about ICP, intracranial pressure? Now let's switch gears and talk more specifically about ICP. According to the Greenberg research, we have cerebral, blood, and CSF. If there is an exponential increase of any one of those components, we may reach some barriers where intracranial pressure will go up and it will become persistent in one of those contents. The brain is a fixed continent which cannot expand, and the compliance laws would take place if there is a intracranial pressure increase. We know that the matter is expansive, can be stretched and become bigger, and this is Professor Mascarenhas' theory. So now let's make an association between severe encephalopathy and a patient with COVID-19. Here we have a severe patient who is sedated, but with no stroke, but the patient is intubated for quite a while. And the question is, how about intubation? How about aggressive intubation mode? And how can that influence the brain values? We know that since the 70s that there is an effect in the hypocapnia, and if you hyperventilate the patient, that leads to a fast cerebral flow decline. And if that flow is too low, there is a return, a change in the CSF. That's why hyperventilation will not last too long in face of ICP. How about a patient who is intubated for a while with COVID-19 with a very variable PCO2? Now we have a patient with a CHI that underwent hypocapnia. They have that CAH, I should say, and that would take to a improvement of their CSF, blood flow. Out of those 12 patients, after hypercapnia, there is a reduction of cerebral blood flow, but the posterior flow increases if you get back to PCO2, as we would expect. And they also advocate that that could be a therapy for long-term ischemia. How about intracranial pressure? Here we have cerebral blood flow, or at the time of ICP, despite that is quite low. Some of the article authors, they advocate for a small increase so we could treat patients with a liquor drainage. If you increase PCO2, there is a vasodilation with an increased risk of ICP increased levels, and the arachnoid levels, they were well monitored, as well as their PCO2 levels that were also monitored. How about our patients with COVID-19 or any other pulmonary or systemic disease which will require intubation? and if they will require an increase or decrease of PCO2 levels or a severe hypoxemia. Transcranial Doppler. We see a reduction of hyperchemia if there is an increase of PCO2 as expected. In addition to hyper or hypocapnia and hypoxia that may change the cerebral fluid flow, we have also the PEEP use, the application of PEEP for patients with degrees of acute lung injury and concomitant severe. What is the benefit of using higher levels of people with patients with or without a brain injury? Neurocritical care abstract shows the effect of PEEP increase in the ICP. The green curve and the purple line, apparently they seem to have some sort of correlation, but there is no significant increase of intracranial pressure correlated to the PEEP increase. But in the purple line, there is a significant PEEP increase for patients with different degrees of injury. Authors, they will suggest that the application of PEEP at with varying degrees of acute respiratory syndrome that may be safe, except if patients, they have a very severe manifestation. Some other articles, they say that the worsening the pulmonary compliance, the better the PEEP application, because the PEEP increase will not reflect or will not be taken to the brain because there was a low level of lung compliance. So that's not exactly what the study is suggesting. Therefore, there is a controversy in the literature and the level of safety to apply high PEEP levels and the relationship to intracranial pressure. How about patients that there are no brain injuries? Quite complex to monitor ICP in an invasive manner or to place a PEEP at the parenchyma region. So we should apply non-invasive monitor, on the other hand, to understand the level of suffer of our patient's brain due to the systemic disease and also due to the ventilatory mode.
Juliano Molin has already presented his paper. It is a publication this year, his master thesis, comparing ICP curves of patients with ICP monitoring, which was invasive as opposed to brain for care. It showed high specificity, and here we have the comparison of patients who had ICP greater than 20 and P2 over P1 greater, so greater P2 than P1. So all patients with ICP greater than 20 had P2 greater than P1, which was worse in time to peak parameter, but showing that this is a tool that can be used non-invasively to monitor our patients, primarily those that have no classical indication of using ICP monitoring because they have no acute disease. This is a study with Tiago Russo and a number of researchers, including Hospital Samaritano, Hospital São Paulo, Beneficência Portuguesa. We used Brain for Care to monitor patients under mechanical ventilation with COVID-19. There were 4 groups because we wanted to see whether COVID-19 had an impact on brain compliance and whether mechanical ventilation was related with brain compliance. We had 32 patients with COVID-19 without mechanical ventilation, 15 with mechanical ventilation, 16 patients in mechanical ventilation, but not with COVID-19 infection, and 24 patients who were healthy. So these are preliminary results. We are still analyzing that. We monitor them closely for 7 days. So we have data here from day 1 showing a greater frequency of P2 over P1, which is higher in patients under mechanical ventilation by COVID-19 infection or not, compared to healthy subjects and those with COVID-19 without mechanical ventilation. We are still analyzing the other monitoring day, but possibly mechanical ventilation seemed to be associated with brain compliance changes rather than COVID-19. Neurological complications sometimes are underdiagnosed, especially in patients who have severe systemic impacts in COVID-19. And this is why neurological monitoring during mechanical ventilation can be used to monitor patients and avoid post-ICU syndrome with or without COVID-19. Neurological impact is impact with worse prognosis when present in COVID-19. So detecting them early is really important. Fortunately, now there are fewer cases of COVID-19, but many neurological impacts were observed during the pandemic, and we should constantly focus on these patients. This is a very interesting editorial comparing blindness during COVID with the book of José Saramagos. So how science has been able to make us see. The editorial quoted him, "I don't think we did go blind. I think we are blind. Blind, but seeing. Blind people who can see, but do not see." So I hope we can stop not seeing and trust science to define mechanisms, treat patients better, and prevent secondary damage associated with mechanical ventilation or any other complications of systemic disease, not only in COVID-19, but in all severely ill patients. Thank you all very much for your attention. Well, Gisele, thank you very much for your excellent presentation. Very important preliminary results considering everything that we've been experiencing with the pandemic and all the impacts it has caused during disease affection and also after COVID. We still need a number of studies to show what can really complicate after COVID, especially considering neurology. And a concern of mine is that the level of cerebral inflammation may be a complicating factor for the blood-brain barrier. Greater, let's say, severity of post-COVID neurological disease, are they correlated with a rupture of blood-brain barrier, which will certainly cause a number of problems concerning brain compliance, which is something that should be subject to study and might be detected by a non-invasive ICP monitor. Would you make some comments about that? I'm delighted to be here with you today. I think there are still a number of uncertainties concerning the long COVID, as it has been called, cognitive complaints in patients that had been infected by COVID-19. There is one thing, which is what we investigated in the study together with Tiago Russo and Amaflav and others, which investigate severely ill patients. In these cases, there are some confounding factors because we have to keep the patient alive, of course. So mechanical ventilation is important, and this is a very broad source of investigation. also explaining what we call post-ICU syndrome. Mechanical ventilation and what we do to treat severely ill patients has an impact in the long run in terms of cognitive impairment. And we observe that in COVID cases and in non-COVID cases. The pathophysiological explanation of patients with mild COVID-19 is something that uh, we won't be able to investigate using brain compliance, but there are some inflammatory markers or maybe serological markers would be better. We have been focusing on understanding the virus in the brain, and we can see that most of the patients, fortunately, has no encephalitis. Even patients with headache, there is no active virus in the brain, at least based on PCR tests. So there are some studies assessing cytokines, and probably this is the best investigation route, and the blood-brain barrier break is probably one of the reasons that explain the symptoms of patients with long COVID. There is here one question from the audience. Even knowing that they are preliminary results, why does compliance seems to be worse in cases with mechanical ventilation? Does it affect other vital signs as well? Potentially, yes. We haven't carried out an action study to show that, but when I started discussing everything that happens in the brain, and when we start manipulating CO2, the brain that has too high or too low CO2, and that can be observed in patients under mechanical ventilation or a hypoxemic brain, it may lead to microischemia, an increase of distal resistance, which may impact brain compliance. This is just a hypothesis. It's just a preliminary understanding. We first try to identify whether there was some abnormality of compliance using a non-invasive monitor. There are many mechanisms to be studied, but that would require a second line of investigation to try to avoid these abnormalities that may be related with the consequences post-ICU and post-infection, post-mechanical ventilation use. Well, thank you very much. Thank you for sharing your experience with us in clinical practice and for making such great contributions by carrying out so many scientific studies. Thank you very much. And now we are going to go. Thank you. My pleasure. Bye-bye.